Dhara ma'am, can we start?
Yes, please.
Hello, good afternoon to one and all. On behalf of IAP technical team, I warmly welcome to all participants and our today's speaker. Welcome to you, ma'am. Before hand over this webinar to our today's moderator, Dr. Riddhi Pandya, I request to all participants please subscribe our own IAP YouTube channel. Thank you.
Um, Hello, good afternoon, everyone. Myself, Dr. Riddhi Pandya. I am working as a lecturer at Khyati College of Physiotherapy. Uh, Today's webinar, which is on pelvic floor dysfunction in women, tackling barrier, has been organized by Khyati College of Physiotherapy and Khyati Institute of Physiotherapy in association with IAP and IAP WC Gujarat. I would like to now hand over to Dr. Dhara Sharma ma'am, introducing our speaker.
Good afternoon, everyone, and I welcome you all on behalf of Khyati College of Physiotherapy, Khyati Institute of Physiotherapy, and Indian Association of Physiotherapy and Indian Association of Physiotherapy Women's Cell for this webinar on pelvic floor dysfunction by Hedwig Niels. And it is my pleasure to introduce her to you all. Uh, Hedwig Niels is PhD in pelvic health, and she is specialized in pelvic floor rehabilitation as well as perinatal physiotherapy and manual therapy. She translates the research to education in physiotherapy, and she practices at Antwerp University Hospital. She is also visiting faculty at Sydney University, and she practices 3D, 4D ultrasound, transperinal ultrasound, and she's very passionate about improving the pelvic floor dysfunction in women. So, who better than her to address this topic of today, pelvic floor dysfunction in women, tackling the barrier? So, I would like to thank you for taking up this session and giving us time for this, uh, for sharing this valuable knowledge with us. And I would now like to hand it over to you, Hedwig. Please start. Thank you.
Thank you very much. First of all, I certainly also wanted to thank you to get the opportunity to give this lecture. It's a very nice way of sharing knowledge across the world and having collaboration. And maybe Corona and COVID-19 have been easing or fastening it a little bit up. So that's a good way of having more possibilities to share knowledge, right?
Yeah, right.
As you already introduced, the purpose of today is to start with actually the content of my PhD lecture. So I will start to share my screen. As you can, then it will be easier for you to follow all with me. Yeah, is this okay? Hope it is. So thank you for the opportunity. And again, as I already introduced, I will give you today an explanation or a lecture about my PhD work, which I finished in 2018. I've also given this lecture 2 weeks ago to the Sydney, to the Australian Physiotherapy Association. That is why you saw it still on the screen. But this was the front of my PhD work. So as you can see, I defended it in 2018. So I have been going on with research since then. But I think to make an introduction to pelvic floor, it's very important to start with the beginning. That's what I'm going to do today. So we're going to start with an introduction.
I'm sorry to interrupt in between, but the screen that we are seeing where your slides are too zoomed out. So, if you can just compress it a bit, because what we are seeing is there is a zoom version of your slides.
That's important what you're saying. Zoom screen.
Maybe if you can, slide down the percentage on the screen, which is given
Yes,
on
I
the.
will. Um,
Okay, I guess from others they are saying that they can see it properly. So maybe you can continue it.
Yes, ma'am. It's so okay.
Yes,
if
okay.
I'm
Yes, fine. Okay.
okay, I'm only going to try to do this. Is this better?
Yeah, everyone is able to see it fine. So yes, you can continue.
Yeah?
Yes.
Okay.
And
Um,
please do slideshow.
yeah, I was doing slideshow.
Yeah.
You want me to do a slideshow again,
Yes, yes.
as it was before? Then it's like this.
Yes, it
Is
is
this,
fine.
is it okay?
Yes, ma'am.
Okay. If any more questions come, don't hesitate to interrupt me. So let me start with an introduction to pelvic floor dysfunction. And then I'm going to show you some of my results. And then, of course, in the end, I will get to the conclusion of my research results and my PhD. And if we go fast enough, we can have some questions afterwards if there are coming some questions. So first of all, let's start with the pelvic floor. As you can see here, the pelvic floor is a very compound structure. That's the first and most important thing to understand. The pelvic floor is not just a muscle. It's not just an easy part of our body. It's very important that we understand that it's a compound structure which is made to close the bony outlet of the pelvis itself. But it's not only consisting out of muscles, it's also connective tissue, it contains nerves and vascular structures. And it's very important to understand that very well. The muscles themselves, I'm not going to dig too deep into the anatomy on this moment, right on this moment, but it's important to know that we have a superficial layer of pelvic floor muscles and a deeper layer of pelvic floor muscles. That's actually the easy way to explain it, also when you're talking to your patients. Another important fact to emphasize is that through the pelvic floor, the urethra, the vagina and the rectum pass through. So we have 3 holes passing through the pelvic floor, through that compound structure. As you see, or as you know, I told you that the pelvic floor is consisting out of muscles. Then it's important to talk about the function of those muscles. When we talk about function, it's important to emphasize that pelvic floor muscles are there to maintain our continence, to make sure that we can hold pee and stool, but also that we can release it so that we can go to miction and defecation. They also contribute in the sexual arousal and our performance, our sexual performance mechanism. And very important to understand is that they're not only there to close and to hold everything from pee and stool, but also to support the pelvic organs, the bladder, the uterus, and the bowel that are encapsulated by the bony structure of the pelvis. So they are very important in supporting our pelvic organs. And they also have an important role in the contribution of our complete core stability. They work together with our abdominal muscles, with our back muscles, with our glutes to make sure that we have a good core stability in our body. So if I explain all that, it's probably already obvious that if we contract pelvic floor muscles, if we squeeze them, they're not only performing a pinching movement, a squeezing movement, but they're also really having an inward lifting movement. If you perform a good contraction of the pelvic floor, they need to squeeze and they need to lift inwards into your body. That supports the supporting function of your pelvic floor muscles. And I was informed that I'm talking to a big audience of physiotherapy students and physiotherapists themselves. Then I think it's not, it's very clear for you that it's not only important to have or to be able to have a good pelvic floor muscle contraction. Women should know how to contract their pelvic floor muscles, But it's not only about contraction and about force. It's also very important that when we want to have a good muscular function, that we know how to relax pelvic floor muscles, that we have a good proprioception or own control of those muscular information in our own body, that we know how to coordinate our pelvic floor muscles in coordination with those core stability muscles, that we know how to use our pelvic floor muscles in functional exercises and in activities of the daily living. So it's not only about contract, relax, contract, relax. No, we need to have a good function of the pelvic floor muscles. And that exactly is what sometimes goes wrong. That is what pelvic floor dysfunction is. If there's something going wrong with the pelvic floor muscles, we can experience a broad range of symptoms. And today we're speaking about those female pelvic floor dysfunction symptoms. You need to realize that it's not only about incontinence, about urinary leakage. There are many more symptoms involved in pelvic floor dysfunction. And this is a very important slide, which I use a lot to explain what pelvic floor problems are. And that's so important that you're able to explain it in a professional way towards your colleagues, but that you also have a very good knowledge and a very clear understanding of how to get the information to women, to all women in your community. So pelvic floor function is not only, as I said, about urinary leakage. Of course, that is one of the most well-known symptoms of pelvic floor dysfunction, but we can also have anal incontinence, which means that you have problems with holding your stool, that you have incontinence problems with stool, that can be liquid stool or solid stool, or it might be flatus incontinence. That means that you're not able to hold gas and that you have incontinence episodes of gas, which is just going out without of your control. Pelvic organ prolapse symptoms are feelings of a dragging feeling in a heaviness in the vagina. So feeling that your pelvic organs aren't supported well enough, but that they're dragging downwards. Other symptoms of pelvic floor dysfunction might be that you have pain, feelings of pain in those pelvic floor muscles, in those pelvic floor structures, that you notice that you might have female sexual dysfunction, that your sexual function isn't going as it should be, that you have pain which is specifically provoked by sexual activities, by penetration, for example, or the opposite, that you have problems not with holding your pee or your stool, but that you have problems with getting it out, that you have problems with emptying your bladder or problems with emptying your bowel, that you are constipated and continuously having problems that the stool isn't getting out as it should be. So you're hearing a lot of different kind of symptoms, and it's very important that we understand that it's not only about urinary leakage. And as explaining that, we're going on with the introduction, and you will see that pelvic floor dysfunction isn't only a complex whole I'm struggling to find my words, no worries. What I want to say is that also the etiology of pelvic floor dysfunction is multifactorial. You have a lot of different symptoms, you have a lot of different risk factors and etiological factors. Which I am the most interested in and was focused on the most in my research are the two in the yellow screen. So you see that a parity, the number of deliveries that a woman has had, is one of the most important etiological factors or risk factors for pelvic floor dysfunction symptoms. And moreover, not only the number of deliveries, but moreover the number of vaginal deliveries is a big risk factor. But also, please notice those other risk factors which I've listed here and which are all evidence-based. We know that, for example, having obesity, having problems with obesity or diabetes, or women that are continuously or chronically smoking and need to cough a lot and produce a lot of pressure into their body, which is going downwards to the pelvic floor. When you need to cough always, you have a lot of intra-abdominal pressure downwards. That's about what we see about respiratory diseases and smoking problems. But also if there has been surgery in the pelvic floor, or if we know that a woman has hormonal changes due to aging or due to menopause, we know that her risk factors for developing pelvic floor dysfunctions are growing. That comes along with the following slide. You can see that the prevalence of pelvic floor dysfunction is quite high in the female population, and that it even increases with age. We actually know that numbers are raising above 50%. So we know that more than 1 out of 2 women will have problems during her life with pelvic floor dysfunction symptoms. And if we focus more on, or what I was focused more on during my PhD, was the perinatal period. So during the pregnancy and after the delivery. Look at these numbers. You can see that 64% of women have problems with urinary incontinence during their pregnancy. So that's a lot. 1 out of 2 of the women remains having problems after delivery. 1 of 3 women remains to have problems of urinary leakage, urinary incontinence. 1 out of 8 of the women also have problems with anal incontinence. They can't hold stool. They have problems with holding gas and holding stool. So those numbers are devastating, actually. And 1 out of 2 of all women that ever had a vaginal delivery knows that she has chances or a bigger risk on having more of those pelvic organ prolapse feelings, more mobility into those organs, and maybe a supportive system that is failing to support the pelvic organs. So you see, it's not a very rare problem. It's a very common problem. Another important thing to emphasize is that pelvic floor dysfunction is not only a medical problem, it has a large and a negative impact on our psychosocial well-being. We know that women refrain from social activities, refrain from sportive activities, might be frightened to come outside because of their embarrassing symptoms. So the impact of these symptoms is very important, and they make it, or that's why they are they're way too often neglected, and they should receive much more attention. And also not unimportant at all, you can also see that what I meant with these icons is that they have a large cost on the socioeconomic society. Actually, there are a lot of costs raising because of incontinence pads, incontinence surgery, etc. So we also know about the psychosocial impact, but also on the economic impact. We know that these problems will raise a lot of economical problems in the future. So that was my big talk to emphasize how important pelvic floor dysfunction is. Luckily enough, we already have a large range of treatment possibilities. They start with conservative treatment, as you can see, like physiotherapy, like exercises. They range up to, at the other hand, the more right side of my screen, you can see pelvic surgery. You have a broad range of different possibilities. But because we're talking from physiotherapy or about physiotherapy today, I can emphasize also that pelvic floor muscle training, so actually performing exercises to improve your pelvic floor muscles, have been evidence-based first-line treatment guidelines in the prevention and treatment of those pelvic floor symptoms during a pregnancy and also after a delivery, and actually in the complete cycle of a woman's life. They have been acknowledged to be, or they should be, first-line treatment. Speaking about that, just to make sure that we're all speaking the same language, because you will notice English isn't my native language either. I'm Dutch speaking. My second language is French, so sometimes you will notice that I struggle with English. But to make sure that we're all speaking the same language about prevention, I always used in my PhD work the definitions of the WHO organization about prevention, which emphasizes that primary prevention aims to prevent symptoms that haven't occurred yet. So in primary prevention, we're really trying to reach women before they've ever had problems with their pelvic floor. Secondary prevention is rather aiming to reach women from the first onset of their problems, to make sure that we reach them as effectively as possible. So as quickly, effectively as possible with the most appropriate treatment. In this case, we're talking about pelvic floor muscle training. So PFMT, pelvic floor muscle training. Tertiary prevention is the other side of the prevention range. And with tertiary prevention, we mean avoiding that symptoms remain chronic or that relapses become or worsen too much. So in tertiary prevention, we need to acknowledge that women sometimes are not able to be completely cured, but that we try still to reach them with the best options to avoid worsening of the symptoms. And as I said, we have evidence-based guidelines worldwide acknowledged evidence-based guidelines that say that pelvic floor muscle training is perfect in the primary and secondary prevention of pelvic floor dysfunction. So that's exactly what I was running against in my PhD, because if the puzzle is that easy as we can read in scientific literature, if pelvic floor muscle training is the ideal solution, then why are those symptoms still so prevalent in so many women? So where are we running against certain barriers? What is our problem? Why aren't we able to reach women with our pelvic floor muscle training and to treat them all? That was the main question of my PhD study, and therefore we defined 3 barriers which we thought we are running against too. I'm going to run through them each separately. The first barrier that we discussed, and as you can see, of course, in a PhD, it's important to have published all of your research. So you can find in this slide all the references, but you can also search them on, for example, PubMed, of course. So the first barrier that I want to discuss today is the barrier of knowledge. What do women actually know about pelvic floor dysfunction and about the pelvic floor itself? And is that knowledge changing to their cycle, through their cycle of life? And are they actually interested in information? Are they eager to know more about the pelvic floor or not at all? Where are we at this moment? That was our first big research question. We performed, therefore, a big cross-sectional survey design. We assembled questionnaires and surveys of almost 800 women and divided all those women in 3 big groups. We had one group of nulliparous women, so women that never were pregnant before. They were all students of the university, so their mean age was above 18 years old, but they were not yet pregnant yet, and they were not in a medical. That's important to emphasize. They were not in a medical educational system, so they were not medical students, not at all. The other group was a group of women that were pregnant or just had their delivery, so the perinatal or the reproductive group of women, actually. And the last group was a group of postmenopausal women, so a group of women which had a older age and had passed their menopause. We published two full texts about it, and in those you can also find the questionnaire that we used, although I need to emphasize that the questionnaire was developed exactly to dig into those research questions to know what do women know about pelvic floor. So it's not, as you can see, it's a very broad and extended questionnaire. It's not for clinical use. It's not if your patient is entering into your private clinic or into your practice, that you will hand him over this questionnaire and that you will say, okay, try to fill in this questionnaire. This is your first exam. That's not relevant at all. It was for us a very extended questionnaire to really dig into the level of knowledge they have, but it's really developed for research. And these are some of the most important results that we found. As you can see, if you see the scores of the three groups, the young group, the perinatal group, and the older group, they all gave themselves less than a 5 points out of 10 on their knowledge. So when we asked them, how much do you think you know about pelvic floor and pelvic floor dysfunction, they all said, actually, we don't know enough to score half of all points. So they know that they have a sparse knowledge about it. Some of the highlights that I can maybe resume for you today is that we found out that many women do know that pelvic floor has something to do with closure, with making sure that you can hold pee and hold stool, but that those pelvic floor muscles also have that supportive function, which I was explaining before, that they also have a sexual function. They didn't know that at all. They actually had a very sparse knowledge also about where the pelvic floor was exactly situated. So they don't know a lot about anatomy at all. I'm speaking now about Belgian women, of course. Maybe it's better in India. Exactly what I was saying also, they know that those muscles are there to close, to squeeze, but they forget that it's also important that the muscles have a supportive and inward lifting function, actually. When we asked them questions about which risk factors they knew, we saw that they were aware that the number of pregnancies, the number of deliveries had something to do with a higher risk of pelvic floor dysfunction, but they didn't know any of the effects, the etiological effects or increased risks that came with obesity, with chronic coughing, with being constipated. They didn't really understand the differences between perineal rupture or an episiotomy, which is sometimes made during a vaginal delivery. So we noticed sparse knowledge about that. And very important to emphasize is they didn't have any knowledge at all about prolapse. In Belgium, the knowledge about pelvic organ prolapse is very limited on the moment. And then at last, the last one that I want to emphasize is the postnatal consequences. When we asked women that were, as I said, not medically educated about questions like, what do you think is normal? Is it normal for women to lose or to leak urine, for example, at 3 months after delivery, or at 1 year after a delivery? Or is it normal that women frequently experience pain at 3 months after a delivery or at a year after a delivery? Or is it normal that a woman has problems to hold stool? All those embarrassing problems. Actually, we noticed that many women are saying, yeah, one, we don't really know, or if they already knew, their view on it is quite negative. They say, yeah, we guess it's normal. So their idea is quite negative. They expect more negative symptoms to be normal. And that's important to realize. Many women think, yeah, probably it's just part of being a woman. It's part of having kids. It's normal to experience those problems. Although we know that it's not normal and that we can do something about that. So those results were very important for us. When we asked them, okay, what about your information? Were you informed about pelvic floor dysfunction? We saw that the young group said, no, never heard of it at all. We didn't feel, or we don't feel enough informed. But even those group of women that are pregnant or just had their delivery, or the group of older women, postmenopausal women, they all have very high numbers. So we see a high prevalence of women that say, that really emphasize, no, we feel too less informed about it. And when we asked, are you interested to know more about it? We saw high numbers. Above 90% of all women said, yes, we do want to receive more information about it. But notice the last or the sentence that I put it on the bottom of the screen. In the youngest group, we added the question, and did you already ever searched the internet? Because we're living in a digital world. So we were suspecting that many women already went on the World Wide Web and looked for some information on their own. And especially in that young group, a group of nulliparous women in which we expect that there is probably not yet a lot of problems with pelvic floor dysfunction. That group said, yeah, we're interested, we do want to receive information, but no, actually, we haven't looked for information ourselves. So those are quite important. That is why we repeated a smaller portion of our research in even a younger group, because we were thinking, what about if they say they have never received information? Then how would the answers be if we target a younger group, a group of adolescent women? So you see that we targeted a group of teenagers with a mean age of 15 years old. And you can see that they also answered, no, never heard of pelvic floor, never heard of pelvic floor dysfunction. We don't know why those muscles are there. And their numbers of being interested in it were lower. To be honest, they were lower, but still the biggest proportion of them was interested to receive more information. If we asked them, how would you like to get informed? They all answered, we would prefer to get it at school during medical education, during our normal group sessions, class sessions about anatomy, about biology. It should be integrated in our normal program. An additional opinion rather that we published was this one, and emphasized really also the fact that we noticed that women know much more about and speak much more about the urinary part, the urinary leakage, the problems with peeing. But if we talk about problems of anal incontinence, stool incontinence, having problems with stool, we really notice that the barriers are even higher, that there are very sparse or way too less women's health practitioners too, women's health professionals, as we all, asking those questions about the posterior compartment, as we say, so about stool, about leakage of facies, of having problems with farting, having flatulence problems. So that was this opinion is especially written to emphasize that it's important for us as women's health professionals too, to ask questions not only about urinary leakage, but also about the back passage, about the stool part. It's so important to ask women about it. And then, of course, I've also added this slide. I'm very proud to say that from your own specialists in India, Dara has also contributed in research. She has used our questionnaire that we developed to do our studies. And she also found out that a large, big group that she consulted of physiotherapy students actually had a sparse knowledge about pelvic floor and pelvic floor dysfunction in India. So these results, I'm speaking about the Belgian results, but they seem quite similar in India too, I guess. And I see that you're nodding, Dara, so I'm going to continue. So clear message about this barrier that we've noticed. There is a clear lack of knowledge about pelvic floor dysfunction, and we shouldn't shut up, and we should exactly do the opposite. We notice that there is a clear interest in information. So that is why we really think that it is very important to improve knowledge, and really our main goals should be to break the taboo about pelvic floor dysfunction, to raise much more awareness about the high prevalence rates, about what's normal and what's not normal, so that women know way better or find better their way to help seeking behavior, find better, they should know better that it's common, but it's not normal, that there are options to be helped, that there are treatment options available, and that it's important to also think about those options in secondary prevention and tertiary prevention. So it's important that if they have symptoms, that they get treated, that they have good solutions to get better in order to avoid that symptoms will only worsen and increase later in life. So we hope to improve knowledge with the final aim, of course, to improve help-seeking behavior, and hopefully also to get them a bit more adherent to their therapy, because that's the difficult part in physiotherapy. We ask a lot of effort from women, so it's important that they have a good knowledge, that they realize enough why they are doing physiotherapy treatments. So it's all about improving awareness, something that I will come back to a bit later during this lecture. You can see that I added some quotes. Take your time to read it. It's important to emphasize we need to ask patients about pelvic floor dysfunction. They are very often embarrassed to mention it themselves, so we really need to ask patients about it. It's important to improve knowledge on all those factors that I was introducing during this lecture. So give them some better knowledge about anatomy, about the functions, and all those different parts that I explained to you during the beginning of this lecture, and realize that information is probably having the best effect when you can give information personalized. Information should be there to reach out to women, not to frighten them. We're not there to frighten women and say, look what's all possible. Certainly when we're aiming to reach women during pregnancy and in a postnatal period, we don't want to make them afraid of, look what is possible, look what could be the consequences of your delivery. No, it's very important to ensure them that things might happen, but that there are solutions, and try to connect with each woman at her personal level, and try to, in some women you will notice that they are specialists in Pilates and yoga, and they're all about their self-control, very very conscious about their core stability and everything. In those women you can give detailed information, while in some others you will have to keep your information and your education really basic, but try to reach out and give personalized information. That's what we really noticed during our research. So we need to empower women, we need to give them information to make them stronger, not to make them afraid, and to improve their own motivation about, okay, I need to do something myself. I can improve my own impact, or I can improve the impact on my own social life. That's our main goal. And that is, I think, not only or not new in these times in which patient-centered care is increasing much more. We see a lot more that the women should be the center of her own treatment protocol. We need to have a psychosocial approach to women, and she needs to be the center. She needs to understand why we are doing, and she is the one who's actually deciding which way we're going all together. So some focuses that we might not forget with these goals of improving knowledge. It's not only giving a lecture, it's having feedback and making sure that we persuade them for improving their own self-control. And then briefly, I still have time to highlight two of the other barriers that we saw in my PhD research. Another barrier that we supposed to be there when we speak about why isn't pelvic floor muscle training working as it should be, and especially when you focus on women, those two following barriers that I'm discussing, we studied in women immediately after childbirth. We noticed that a lot of women think, okay, you're talking about prevention, you're talking about doing exercises, but please, I just had a vaginal delivery and that hurts. Go away with your exercises. In the beginning, it will be too painful. I'm not starting with exercises yet. And that is also a barrier. So if women think that pain is going to be a problem in their starting of exercises, yeah, then probably they're never informed enough. They don't get to exercises because they're fear of pain, and we can't reach them well enough. So from own expertise, I do acknowledge and I do agree that after a vaginal delivery, of course, you can feel very sore down there and it might hurt a little bit. But our main question was, if we compare normal activities of daily living and also, for example, having to go to the bathroom to pee and to make stool, and just standing up from a stool, having a transfer from sitting to standing, from lying down in your bed, standing up, turning inside your bed, all those activities of daily living, we know that they are painful, that they are provoking perineal pain in women immediately after childbirth, and especially after vaginal childbirth. What about pelvic floor muscle exercises? That was our main question. If we ask women immediately after they have had a delivery, just contract and you relax your muscles, start with exercising immediately now, then what will their answer be? Will they experience perineal pain? Will we provoke and worsen their pain? Or is it actually okay? And that is, we've set up, I'm not going to go too much into the details. If you're interested, you can read the articles and the full text, of course, because they're all published in the European Journal of Obstetrics and Gynecology, as you can see down there. But our setup or our protocol was that we saw them, as I explained, immediately after childbirth. We let them, we asked them to perform some activities of daily living, and we asked them about their pain score on a visual analog scale from 0 to 10. They needed to rate their intensity of pain during those activities and also during a pelvic floor muscle contraction. And then 9 weeks later, we had a phone call assessment with them, and we asked them to do the same thing. We asked them about their pain scores during activities of daily living and during an analytic contraction of the pelvic floor. And these were our results. So you can see on the top left part of the screen, you see the visual analog scale scores. And you will see that the pain scores, so the pain intensity that was felt during activities of daily living, during micturition, so peeing, or making stool defecation, the pain scores were significantly higher compared to the pain that they felt during a pelvic floor muscle contraction. On the right side of the screen, you see the prevalence of pain. And you will notice that the occurrence, so feeling pain, was much more prevalent during those normal activities of daily living, during transfers from sitting to standing and moving in bed, compared to the pain that they felt during pelvic floor muscle contraction. So we asked all those women to do an analytic contraction of the pelvic floor in their maternity bed, in their hospital bed, and only in a few, I think only in 2 or 3 out of all of them, it provoked a little bit of perineal pain. So our conclusions, before I come to the conclusions, we, as I explained, we also called them back after 9 weeks. After 9 weeks, you can see that the scores on pelvic floor muscle contraction lowered to 0. So after 9 weeks, we still had quite a lot. 1 out of 3 of the women said that they still sometimes experienced perineal pain, so pain in the pelvic floor, for example, during sexual intercourse, sometimes during activities of daily living, sometimes during defecation, making stool. But if we ask them, and how about during exercises, when you are then exercising your pelvic floor muscles, are you still experiencing pain? We saw that none of them had pain after 9 weeks. So that made us, or that strengthened our conclusion that perineal pain is, of course, that we knew that already from the literature, but we confirmed it with our own study. Perineal pain or pelvic floor pain is quite prevalent, highly prevalent in women immediately after childbirth. But we can ensure women that if they perform easy basic exercises of the pelvic floor muscles, if they're just contracting and relaxing their own pelvic floor muscles, they will not worsen their pain. They will not provoke pain. So they shouldn't refrain from starting with exercises because they have fear for pain. So that was our second barrier that we tackled down. And then at last, if we then know that women can start immediately after childbirth with exercising, then we thought it's maybe still important to look at how are they starting with exercising. How well are women exercising if we ask them to contract their pelvic floor muscles if we see them immediately after childbirth? Or on the other hand, which common errors might occur? And we defined COMOVE. It was an acronym for common contractions of other muscles or other movements performed in addition to or instead of the pelvic floor muscle contraction. To be clear about it, so we asked women, contract your pelvic floor muscles as you would do to hold pee-pee or to hold stool, to hold gas. And we assessed them during that contraction, and we wanted to know how common, so how prevalent mistakes were, as for example, instead of contracting their pelvic floor muscles, they were contracting. They said, yes, I'm performing my pelvic floor muscle contraction, but they were instead contracting their abdominal muscles or their adductors, or they were contracting their glutes. You saw them doing like this. They were contracting their glutes, but they didn't do anything in their pelvic floor at all. Or some women even say, you see them holding their breath, but they're not really contracting the pelvic floor muscles, or they're tilting their pelvis, but they're not doing those squeezing, inward lifting contractions that we need to have in pelvic floor muscles. So the aims of this research were to evaluate how prevalent are those common mistakes on one hand. If they are performing those mistakes, is then their pelvic floor contraction itself less effective? And is it possible to unlearn or to correct those common mistakes and to make sure that they leave those mistakes behind and they perform a better contraction after we give verbal feedback as a physiotherapist? We also assessed a large group of women. We saw around 400 women, also immediately after delivery in their hospital bed. it was a different population of women, and it was performed during another year. It's also all published in the European Journal, so you can read it. And as I said, so our protocol was we asked those women who just had their vaginal delivery to perform a pelvic floor muscle contraction. We saw what was happening. We didn't palpate yet because they just had their delivery, and then in Belgium we're not allowed to do a vaginal palpation yet. So it's about the first instructions that we can give after a vaginal delivery. So we only saw with visual observation what they were doing. We asked them to lower their panties, that we could see and control the naked pelvic floor, but we did no palpation. We saw about what common mistakes are also performed, and we teach them how to adapt their contraction, how to correct those common mistakes, and we ask them to do it again. And our results were the following. So we saw that those common mistakes occurred in more than half of all women. So more than half of all women did a wrong contraction, performed a contraction of other muscles, but not their pelvic floor muscles, or did it in a combination, but were less effective. Because that's what we found out with the correlation. If they were performing those common mistakes, such as breath holding, contraction of their abdominals, contraction of the glutes, their concentration on their pelvic floor was too less. And we really noticed that the pelvic floor muscle contraction itself was less effective. So it has a negative effect on the effectiveness of our final goals of pelvic floor treatment. On the other hand, the good news was that when we gave them verbal feedback, just by having a visual observation and by giving them good explanation about how to correct those common mistakes, we saw very good numbers, and we saw that almost all women were able to abandon those common mistakes and to perform a way better pelvic floor muscle contraction. So that made us, or that drove us to the conclusion that, as we know that pelvic floor muscle training is worldwide acknowledged as the first line treatment goal to perform in the prevention and treatment of pelvic floor dysfunction, it's important to be able to start with a good analytic, a good specific contraction of your pelvic floor muscles. And therefore, we found out that it's important to do a real control, to do a visual control, to look at how women are performing their contraction, to make sure that you can give them feedback if you see common mistakes, and that verbal feedback is very effective in abandoning those mistakes. If starting so early with pelvic floor muscle contractions immediately after childbirth is still in research. I need to acknowledge that. There are some researchers working on the time slot now. So in many countries around the world, it's common to say just start with physiotherapy after 6 weeks. Our results now that I am presenting to you today really emphasize that we can start way earlier. We don't have any contraindications to postpone treatment. We can start way earlier with promoting exercising, with giving good information. But I need to acknowledge that we don't have hard evidence yet to say that it will improve our results if we start earlier, if we start immediately after delivery. On the other hand, in our system, in our Belgian system, we see women a lot during those first days after delivery. So it's the perfect opportunity to reach them with information and to get them into a pelvic floor muscle training program. Of course, the beginning is focused on proprioception, on easy exercises. We don't need to emphasize yet too much how many, how frequent, how forceful exercises need to be. It's on their own tempo, on their own timeline. They just had their delivery, but we don't have contraindications to postpone it. So please start with advising them yet, informing them yet, confirming that it will not hurt and that it's important to do exercises in a right way without those mistakes. That's actually what we are doing in our hospital too. This is an information leaflet, a Dutch information leaflet that we are using in our university hospital now in Belgium. So the focus should first be on restoring the analytic control, and then later in the further future of your rehabilitation protocol, of course, it gets important to put your focus also more, as I started with, towards integration into activities of daily living, functional activities, coordinational activities, core stability exercises, and more of those. So that brings me to the conclusion of the results of my PhD. And that's why we developed this image or pictogram or infographic, or call it as you want. But we want to repeat again that we know that pelvic floor muscle training is advised, or is a good way to reach prevention of pelvic floor dysfunction. But we found that there are certain barriers that are withholding us from being effective enough to treat women of all ages towards with effective prevention programs. The first barrier that we found is, as I said, the knowledge barrier. So we found out that there's a sparse knowledge about pelvic floor and pelvic floor dysfunction, and therefore our advice is to improve the timing, get women informed even in their adolescent years, improve the way you're giving your information, improve the way you're giving your educational programs. Make sure that you reassure them that you reassure a group of perinatal women during their pregnancy and after delivery, that they can start with exercises yet during that very important phase of their life, that it will not aggravate their pain, that they can start with pelvic floor muscle exercises, but that it is important to tackle that third barrier, those common errors. If they start exercises, they should get controlled, they should get your advice, your professional advice, to make sure that they are performing their exercises right. Many women think that they are performing it right, but they're not doing it well enough. So if we tackle all those barriers, we hope that we will be able to break the taboo about pelvic floor dysfunction, to raise much more awareness about the importance of pelvic floor dysfunction, and in the end, as I was explaining before, to improve help-seeking behavior in women of all ages. And that was what we aimed to reach with the results of my PhD. I think I'm speaking to a big audience of very diverse levels of education. For some of you, it will have been all new. For some of you, it will not have been new at all. But I hope that even for the specialists in pelvic floor dysfunction beneath your group of participants, it will also empower you. So we've published all the evidence base. The full texts are all on PubMed, so you have the evidence to prove to other healthcare professionals that your role is very important. So use it in getting the message out to women of all ages. And then I want to thank, of course, I didn't perform this research alone. You can see that I was supported by a big team of other specialists in our university hospital at the Antwerp University in Belgium. It was a very, very nice challenge for me. It was not always easy, as you will probably all know. Performing a PhD or writing a PhD is a very challenging trajectory or journey to do, but I loved to do it. And although I would have loved to give you all the perfect answers, I need to acknowledge that if you start with research, you're probably ending with more missing pieces than the ones you are than the research questions that you started with. I'm not a guru who said that I found all solutions, but on the other hand, never be disappointed. Performing research is so interesting. It's leading towards new insights, and that's what I'm doing now too. We're 2 years behind this presentation now, so I'm continuing with postdoctoral research. Some of the things that I'm doing right now is putting a lot of emphasis on research communication, having the opportunity to lecture about research as we are doing right on this moment, putting effort in having more reachable, accessible information out, as for example, this platform was offering another way of bringing some of the research results again. You can look for these links. They're giving a more structured or more summarized way of research. It's quite interesting for physiotherapists to review those. And my last and most recent project that I performed in Belgium is this one, the pelvic floor. It's a digital information platform, because it's an important thing to emphasize at the end of this lecture. I'm claiming and I'm saying that it's so important to improve knowledge, but it's not easy to get knowledge out in an attractive way. Many women still refrain from information about the pelvic floor. And that is exactly why we're trying now in Belgium to do a campaign which is accessible and attractive. We've developed a big website. You can see that it is in Dutch, so you will have difficulties in understanding, but you can see the big slogans that we're using on the left side. It's all aiming to raise awareness, to break the taboo, to empower women. And we're trying now to do it a bit more attractive, accessible. And I hope that in a few years, I will be able to give you the results of those campaigns. And I will hope that if I would do a new review about the level of knowledge, that it will improve by challenges and opportunities as these, as a digital platform, which you can see here and quotes on social media. And then I see that Dara Sharma is coming online too. I came to the end of this lecture. I don't know if there's still time left for questions, or that we keep those for the future.
Yes, Hedwig, it was a very beautiful presentation that we had, and some of the insights that you shared were like, really eye-opener for us rather. Uh, there are a couple of questions only which has come up, so if you can just answer them quickly, the participants would be really glad. One of the question is that why back pain and pelvic floor muscle dysfunction are usually associated?
That's a very good question. From clinical expertise and also from evidence-based, we know, or we're seeing much more that back pain and pelvic girdle pain are associated with pelvic floor dysfunction, and that the emphasis in pelvic floor dysfunction in those women is that they rather have an overactive or an hypertone pelvic floor. So if you're working with women that have a correlation between back pain and pelvic girdle pain and pelvic floor dysfunction, make sure that you assess them well, and that you don't only put the emphasis on improving their pelvic floor strength, but that you also teach them what I started my lecture with. It's so important that women have a good control of their own body. It's not necessary to keep your pelvic floor muscles contracted as being strong always during your daily activities. It should be relaxed, it should be loose. Only when women feel the urge to go to the toilet, the urge to pee or to make stool, at those moments they need a contraction of the pelvic floor muscles. But the women that are having an overactive pelvic floor and that are having an hypertone, an increased tone in those muscles, all day long, they are probably triggering their neuromuscular pathways towards their cerebral systems, so they're more central systems, and they're probably triggering their system way too much towards central sensitization of chronic back pain and chronic pelvic pain. So if you're interested to dig into that topic, you really need to think about hypertone, overactive pelvic floor muscles, and how to get them a better contraction and relaxation, a better normal tonicity in those muscles.
Right. Thank you. There is a few more questions which are coming up. Do we have time to address them?
Yeah, for me, no problem.
Okay. So maybe for another 5-10 minutes we can go ahead and then we will end it in another, say, 10 minutes more. Is
Okay,
that okay?
that's okay.
Yeah. So one more question which has come up is that can postpartum depression be associated with pelvic floor dysfunction?
Uh, the pressure, what exactly is the question?
Postpartum depression, the depression which comes with.
Depression. Yeah, there is a high. That's a very good question, and to be honest, it's on my to-do list to dig deeper into those topics, or to make sure that I know the evidence which is published about that more. And with the pelvic floor platform that I just showed you, so we're now setting up yeah, we're trying to reach a community, we're trying to reach women with social media, and I do realize so much from those kind of initiatives, and also from my own clinical practice, that of course the impact of pelvic floor dysfunction is so high in women, and if they are postpartum, of course we do know that there needs to be a relation with postpartum depression. But to be honest, I need to acknowledge that I can't give you the hard numbers by head from the published research about that. But that's why I think it's so important to have a big team or a multidisciplinary team of specialists around you. The pelvic floor, the initiatives that we are doing right now are also supported by a big team in which we have gynecologists, general practitioners, we have midwives, physiotherapists, we have psychologists, and even women peer reviewing women testimonies of women that are helping each other. I think it's very important to have more focus on those psychological effects, but I can't refer to the literature that much because I don't know it by heart yet or by head yet.
Okay.
But it's a good question.
Yeah. Can we use biofeedback or any other feedback in teaching correct pelvic floor muscle contraction training?
You can certainly, but from my clinical expertise, I think that it is even, if you're speaking about proprioception, about the first parts of learning a woman how to contract, I feel more confident with doing a vaginal palpation, and you can do it externally on the perineum to start. Even if you put one finger on the outside of the vagina and you say, okay, you feel my finger, try to pull your pelvic floor muscles away from my finger and try to relax, and try to, by explaining, by touching, by giving a palpation, I think you reinforce the female internal control way better and way more than using biofeedback. Although in some women, if they really struggle to contract their muscles, biofeedback can be used. It can give indeed a visual, an added visual tool to see if they contract, how high your graphs are going up or down. So visual feedback might be an added value, but me, in my own practice, I work a lot more with vaginal palpation from external and from internal. And of course, as you were saying in the introduction, I am now specialized in 3D and 4D ultrasound. So I'm tending to use my ultrasound more than biofeedback. But ultrasound is quite expensive. I know that I'm privileged to work in the university hospital where the gynecologists, they do have ultrasound. And when you use ultrasound, you can also use it as a visual or a visual tool to teach women how she's contracting and relaxing. So I'm tending a bit more towards that way, but for a general practitioner, for a physiotherapist, biofeedback can certainly be an added value, but start to emphasize first that vaginal palpation from external and internal is the first and most common way to start with it. It's the tool that every woman has in her own hands. You can also teach her how to feel, how to touch herself, how to feel the muscle beneath her fingers moving. Give her comparable signs. Teach her that if she's contracting her arm muscles, she can feel tension in a muscle. That's the tension she should also be able to feel in the vagina, in the pelvic floor muscles. You really need to try to get her along into the path to improve her proprioception. And I think biofeedback is not necessary for that.
Okay, that's very good suggestion that you have given, because using just the hand or fingers, that is like a much cheaper and easier tool that every woman will have. So
Yeah,
better
it's
than
much
that.
more accessible.
Yes,
Every woman can do it for
and cost
herself.
effective.
Yeah,
So
yeah.
yes. Okay, there's one question which asks if this aerobic exercise can lead to weaken the pelvic floor muscles and leads to intermittent bleed.
Yeah, that's a very good question, and that's a hot topic in pelvic floor research too. Caribou is undoubtedly the leading lady in the number of articles she has published in pelvic floor research, and she has lectured about the correlation indeed between physical activities on one way and pelvic floor dysfunction on the other way. Is increasing physical activities increasing the symptoms, or on the other hand, is it a good way to treat symptoms and to prevent symptoms? Now we're seeing that it's all about control. It's important to have a good coordination of the pelvic floor while physical activities and fitness activities are performed. So start easy, start with those analytical contractions. Make sure that women have a good analytical, simple and easy basic exercise, and try to increase that and implement that more and more into the physical activities. If a woman knows how to engage her pelvic floor, we then see and we then presume that physical activities will not worsen the status of the pelvic floor at all. It will strengthen it because you have more challenges for your pelvic floor, you have more ground reaction forces, and you see that the pelvic floor muscles are oftenly even getting stronger by doing general physical activities. But don't misunderstand the message. You cannot think that only doing fitness activities without talking about the engagement of pelvic floor hasn't shown to be effective way of treating pelvic floor disorders. So we cannot say that, for example, yoga, Pilates, fitness activities are effective to treat pelvic floor dysfunction if we are not sure that pelvic floor muscle exercises are integrated in it. So if we can work in a complete combination, we hope to improve pelvic floor problems, but it needs to be emphasize first that you start with very easy analytic selective control of the pelvic floor.
Right. Okay, and this is the last question that we'll take for today, and that is asked by one of the student, I guess, that which is one of the best method to assess pelvic floor muscles.
Yeah, that depends about the situation and about your level of expertise, of course. If this question would be asked by a general physiotherapist who is having or who is seeing a lot of women and who gives manual therapy and functional exercises, then don't be afraid just to ask a woman about if she feels it and how does she feel it, and then you can give simple tips like, if you go to the toilet and you're having a wee, try to stop weighing and release again. If you know for sure that you're stop weighing during you were peeing, then you know that you're using your pelvic floor muscles on the right way. So a general physiotherapist can already ask some good questions to have a very, very small assessment of the pelvic floor muscles. But if you're really asking this, and of course, then you have the different levels. You can do an external palpation. If you palpate externally, you can put your fingers on the perineum. That's what my advice would be. Put your fingers on the perineum, so on the skin between the vaginal introitus and the anus. If you put your finger over there and you can feel the muscle contraction, which is squeezing and an inward movement, you can already have an external palpation. You can look at the pelvic floor, so you can do a visual observation. But if you really want to make sure that you're performing a valid and a reliable assessment of the pelvic floor muscles, then you need to perform a vaginal palpation. So you're going inwards with your fingers, and then the scheme that I am advising the most is the perfect scheme. It's published by Joe Laycock. It's not new, it's not recent, but it has very good validity and reliability, and that has that includes the modified Oxford scale. So it's a scale from 0 to 5, in which you can appreciate the force of the pelvic floor muscles and their ability to contract against resistance, against gravity. And in the perfect scheme, you also make an assessment of the number of maximal contractions, the endurance of the muscles, of the contraction, the muscle contraction itself. So the perfect scheme of Joe Laycock is a quite good and reliable way of performing a good specialized vaginal examination. But that doesn't mean that if you're a general practitioner, you can already do some good tips or gifts. You can do a visual observation, you can do an external palpation, you can ask some questions about it. That might also give you already a good idea about pelvic floor.
So with this question, we end the session over here, and I'm really grateful to you for sparing this time for us and sharing your knowledge and answering all these questions. And some of the things that you are doing, I would like to congratulate you for raising this awareness about the pelvic floor function. The work you are doing is amazing. So good luck for that. And thank you on behalf of Khyati College of Physiotherapy, Khyati Institute of Physiotherapy, Indian Association of Physiotherapy, and Indian Association of Physiotherapy Women's Health. And thank you all the participants for attending this webinar and making this interactive and interesting. Thank you so much.
On
Okay.
behalf of IAP technical team, I am thankful to IAP and IAP Women's Cell Gujarat team for organizing wonderful webinar. Also, so much thankful to our today's speaker for sharing knowledge. Thank you so much, ma'am, and all participants because of that this webinar made it successful. So thank you all participants. And last but not the least, I would like to thank our IAP President Dr. Jha sir and our IAP Women's Cell National Head Dr. Ruchi ma'am for providing a platform for a learning. Thank you so much. Before the end of this session, I again request to all participants please subscribe our own IAP YouTube channel for watching more live webinar. Thank you so much to all.
Thank you very much, too. It was an honor for me, and I hope we will all be able to raise more awareness across the world, and we will be able to share more knowledge and newer insights about upcoming and future research in the future.
Thank you.
It was my honor. Thank you, too. Okay, bye.
Bye.